Welcome to the annual CAMR lectureship. Unfortunately, Dr. Gilbert couldn't be with us this morning. He usually does this portion of the introduction, so I'm stepping into his very large shoes, but I will do my best. Just to give you a little bit of background, Dr. Huldrych CAMR touched countless lives as a role model physician, pioneering endocrinologist, and he was one of the first endocrinologists in Oregon. He was a gifted teacher and a lifelong learner. He served as Associate Director for the Internal Medicine Residency at Providence, Portland for 30 years, and over those decades trained hundreds of residents, fellows, and medical students who benefited from both his love of teaching and his passion for lifelong personal scholarship. Because of this love of endocrinology and teaching, Dr. CAMR established this lectureship prior to his passing in 2003. It's also generously supported by the Providence Foundation, so thank you for that, and also by his family. And his daughter is here today, Reverend Christine Dungan, who also helps to support this program. In planning this program, we kind of established who the speaker is going to be for the following year at a dinner we have the night before. And we always try to choose speakers who have expertise in education. And I think today is absolutely no exception. Our speaker today is Dr. Mike McDermott. He is a professor of medicine and clinical pharmacy at the University of Colorado. And he is the director of the endocrinology and diabetes practice at the University of Colorado Hospital. He went to medical school at Tulane and spent 20 years in the U.S. Army, where he was chief of endocrinology at Fitzsimmons. And he served as an endocrinology consultant for the Surgeon General. He then retired and went on to join the faculty at the University of Colorado. And I think, like Dr. CAMR, one of the things that I appreciate about Dr. McDermott, who was one of my mentors at the University of Colorado when I was a fellow there, he has a breadth of basically all things endocrine. So today he's going to be speaking to us about hypercalcemia, but he can talk to you about and teach you anything related to endocrinology. So I'm really, really glad to have him here today to speak to our group. So thank you, Mike.
Okay, thanks, Liz. Okay, well, thank you, Liz. That was really wonderful, and I have to tell you how proud I am of Liz Stevens, one of our best fellows who comes into a community like this and just really gives her best to make the community health better. I'm really honored to be asked to give this talk. I didn't know Dr. CAMR, but I did meet his family last night, and Christine especially. I think that's something I really think I missed is meeting Dr. CAMR. He sounds like a wonderful doctor and a wonderful teacher, and we really need teachers that we can learn from and who can teach us and inspire us to be better people and better healthcare providers. So I hope today that I'm able to do justice to this honor you've given me. Once again, thank you. So Liz did ask me to talk on hypercalcemia. It's actually a pretty common disorder among electrolyte abnormalities with some very important causes. And there's a long list of causes. 5 are very, very important for us to make sure we diagnose. So let me just comment first of all on serum calcium. Like potassium, calcium is regulated within a very narrow range. So the normal range for serum calcium is 8.5 to 10.5 at the University of Colorado. It might be slightly different here. So it's really a fairly narrow range when you look at a lot of other things we measure in the blood. And the body really makes multiple efforts through different mechanisms to keep that blood calcium level exactly where it is. If you were to measure your blood calcium level this morning and it was 9.5, if we then checked it every day for the next month, it wouldn't vary more between 9.4 and 9.6. It wouldn't go outside that range. So the population range is pretty narrow. Each person's individual range is very narrow. We keep it very closely regulated. So that if somebody's serum calcium is 9.5 and it drops down to say 9.0, the body has pretty aggressive mechanisms that it utilizes to bring the calcium right back up to where it was far before it gets outside the normal range. So if the calcium level dropped, we would make parathyroid hormone. We would convert 25 hydroxyvitamin D, the storage form of vitamin D, into 125 dihydroxyvitamin D, which is the activated form, and we would suppress production of calcitonin. Whereas if our serum calcium started rising and got to 10.0, still within the normal range, our body would initiate these mechanisms. We would stop making parathyroid hormone completely. We would stop making 125 vitamin D, and we would make calcitonin to inhibit bone resorption. So the body really, as I said, regulates calcium very tightly. How does it do this? This was one of the remarkable discoveries of the 1990s. We never really knew this until some very good scientists determined that there's a protein called the calcium sensor receptor that sits on the cell surface of most cells in our body, but especially parathyroid cells, parafollicular C cells in the thyroid gland, and renal tubular cells. And what it does is it senses what the extracellular calcium concentration is. So calcium binds to the extracellular portion of this receptor, and it signals to the inside of the cell what that calcium level is. And if it's a parathyroid cell, that regulates whether PTH is produced. And the other cells, similarly, it tells them what to do. So that's how this is all regulated and orchestrated, and it's a very tight and very elegant system. So when a person develops hypercalcemia, there are distinct abnormalities, and all of us who have been doctors for a while will remember that there's little mnemonics that we did remember the 15 or so different causes of hypercalcemia. It didn't necessarily put them into the right order, like what's the most important, what's the most common. So I have a different classification I'd like to tell you about, and it's really more mechanistic based. So what causes the hypercalcemia? And then I'd like to focus on the 5 most common causes of hypercalcemia and how we manage those today. So the first mechanism is parathyroid hormone dependent. That's where parathyroid hormone is being made in excess, and that's what's driving the serum calcium up. The most common cause of hypercalcemia of all is the hyperparathyroidism, where we develop an adenoma or hyperplasia of the parathyroid glands. But also people who take chronic lithium for bipolar disease, they may develop, and they frequently do, hyperplasia of all 4 parathyroid glands, and so they produce too much PTH, and they get hypercalcemia. And then there's a rare genetic disorder where the calcium sensor receptor that I just showed you, that protein on the surface of cells, is mutated in such a way that it's underactive. It doesn't recognize serum calcium, and it causes the parathyroid cells to produce too much PTH. The second mechanism is dependent upon too much 25-hydroxy vitamin D. So when we take vitamin D in our diet, or if we get it through the sun exposure to our skin, we store vitamin D as this storage molecule, 25-hydroxy vitamin D. And if we have too much vitamin D toxicity, that increases the intestinal absorption of calcium and causes hypercalcemia. Hypercalcemia can also be driven by the activated form of vitamin D when vitamin D levels are otherwise normal. And there's a number of disorders where the enzyme that converts vitamin D into 125 vitamin D are activated. And so the most common of these is sarcoidosis, and I'll spend a little bit of time telling you how that happens. And also lymphomas and granulomatous disorders, and then some rare mutations of an enzyme. Another driver of high calcium can be PTHrP. This is a protein that I'll tell you a little bit more about that's often made in cancers. So this is what is the mediator usually of hypercalcemia of malignancy. So hypercalcemia malignancy occurs in basically 2 different forms. The first is humoral hypercalcemia malignancy, where a large tumor that's not necessarily metastatic produces a large amount of parathyroid hormone-related peptide, and that circulating level of PTHrP is what causes hypercalcemia. The second is called local osteolytic hypercalcemia malignancy, and this is where tumors, cancers, like breast cancer that metastasize to bone, produce a lot of local PTHrP right on the surface of bone that stimulates osteoclastic bone resorption, causing hypercalcemia. Then we have other mechanisms. There's always others because we can't explain everything. And the most common of these is milk alkali syndrome, where people take too much calcium supplement in the form of calcium carbonate. Then a number of other disorders I won't have time to touch on, but hyperthyroidism, thiazide diuretics, acute renal failure, adrenal insufficiency, vitamin A intoxication, and immobilization. So this doesn't happen in adults very often, but you take a teenager who breaks a bone and you have them go in bed rest for 3 days, their calcium level will rise above the upper limit of normal. So how do we evaluate? How should we approach a person who has hypercalcemia? The first thing we need to do, of course, is to look at the patient, to talk to them. So a good history and physical examination is critical to understanding the cause and managing hypercalcemia in an appropriate way. Then we do labs, and the most important lab test to measure is a parathyroid hormone level, because we need to establish whether this is the most common cause of hypercalcemia, which is parathyroid hormone driven, or whether it's something else. And then we want to rule out some other things. So the creatinine, carbon dioxide, and phosphorus levels are critical for evaluating the cause of hypercalcemia. Now, if the PTH level in the face of hypercalcemia is elevated, or if it's normal, that indicates that PTH is the driver of the hypercalcemia. So that's where we have these disorders that I just mentioned. Primary hyperparathyroidism, most commonly, lithium-induced parathyroid hyperplasia in those patients, and then a rare mutation that we don't see very often. Now, if the PTH is low, it's going to be driven by one of the other mediators I talked about, or one of the other mechanisms I mentioned a minute ago. The first thing to look at is the creatinine and CO2. If these are increased, you probably have milk alkali syndrome. This is the third most common cause of hypercalcemia. If the PTH is low and the creatinine and CO2 are normal, measure 25-hydroxy vitamin D and a PTH-RP. If the 25-hydroxy-D is elevated, they've been taking too much vitamin D. They have D toxicity. If the PTH-RP is elevated, they have a cancer somewhere. We might know what cancer they already have. It may be a known cancer patient, but sometimes this is the clue to an unknown cancer, an occult malignancy somewhere that we need to go on a cancer search for. So high PTH-RP levels would indicate that. If the PTH-RP is low, the vitamin D is normal, we measure 125 dihydroxy vitamin D and then do an SPEP and a UPEP. If 125 levels are high, then typically the most common cause is going to be sarcoidosis. The second most is going to be lymphomas. So this is a really important area, and we often miss these. And these are critical diseases that sometimes present simply with hypercalcemia. Then, of course, if the UPEP and the SPEP are abnormal, you have multiple myeloma, and that's a very serious hematologic malignancy. So that's an overview of how we should evaluate for the different mechanistic causes of hypercalcemia. So what I'd like to do now is take 5 different cases that illustrate the 5 most common and, in my opinion, most important causes of hypercalcemia, the ones that we should not miss. Okay, these are the ones that primary care doctors or endocrinologists can all work up, and we shouldn't miss these diagnoses. And I'm going to spend a little bit more time on the first one because it's the most common. So the patient was an 18-year-old male who came in for an 18-month history of right-sided facial swelling and a left hard palate mass. On physical exam, that was what was seen. He had an otherwise normal exam, but he had a firm right facial mass and a large left hard palate mass. He had some basic laboratories, and his serum calcium level was significantly elevated at 17, and that exceeds what we call a hypercalcemic crisis, which is 14 or above. His phosphorus was low, and that's a very big diagnostic clue, and I'll talk more about this as we go on, but phosphate, or the phosphorus level, is never diagnostic, but when the phosphate level is low and the calcium is high, it almost always tells you that it's a parathyroid hormone-driven hypercalcemia, because PTH raises calcium and it lowers phosphate. So although he had a pretty scary presentation and a high calcium level, the fact that the phosphate is low is somewhat reassuring that he may have a benign condition. Creatinine and albumin were okay. So this was actually a publication also, and this is a picture of him here. You can see he has this right facial mass and a left hard palate mass. So in an 18-year-old, this is really scary for a possible malignancy. Again, very significant hypercalcemia. Somewhat reassuring, though, that his phosphate is low. So what we need to do, first of all, is measure a parathyroid hormone to see if this is PTH driven or not. And his PTH, in fact, was elevated. And that would be a big relief to me if I were his parents or if I was the patient or his physician, because that means he's got hyperparathyroidism. He doesn't have a malignancy. He had a biopsy of this right maxillary mass that looked pretty scary. And what it was a brown tumor. A brown tumor is a benign tumor that consists of osteoclasts. So another term is an osteoclastoma. And these benign tumors don't require removal. They don't require excavation. They actually just melt away as soon as you treat the primary cause, which is hyperparathyroidism. So we went to parathyroid surgery. He had a 2.0 by 1.5 centimeter left inferior benign adenoma. Pretty big, causing pretty severe hypercalcemia, and this brown tumor, which was present in his right face and in his left hard palate. Both of these resolved gradually over the next 6 months. So primary hyperparathyroidism occurs in several different forms. The most common type of primary hyperparathyroidism is a solitary benign adenoma. That's about 85% of people. When this disease is sporadic, that's usually what we see as an adenoma. So it's enlargement of one parathyroid gland, and the other parathyroid glands actually shrink because they don't have to work. About 15% of the time we see parathyroid hyperplasia, where all 4 glands are enlarged. This is more difficult to treat, but more importantly, this is what we see in the familial disorders, because familial disorders are due to germline mutations, and I'll talk about some of those in a moment, but it causes enlargement of all 4 parathyroid glands. So when we see parathyroid hyperplasia as the cause of primary hyperparathyroidism, we need to think about familial disorders, and some of those keep some company with some pretty bad actors that we really have to be aware of. Parathyroid carcinoma is not common. It's less than 1% of all cases of primary hyperparathyroidism, but it's pretty aggressive locally. So it grows into the strap muscles and into the trachea. It's difficult to resect and does cause a pretty significant mortality. We suspect parathyroid carcinomas when PTH levels are very, very high and calcium is very high. So the most common cause is just a benign solitary parathyroid adenoma. What clinical features does primary hyperparathyroidism cause? Most often, this is asymptomatic. We do labs on most of our patients nowadays every year when they come in for their general exam, and so a basic metabolic panel, which has a serum calcium on it, that is usually the test by which we diagnose asymptomatic hypercalcemia. So most people just have a high calcium, and they really don't have significant symptoms. If you go back in time to when I was a fellow and we didn't necessarily always have calcium in the basic metabolic panel, you would read the books that said, we saw a lot of skeletal disease like osteoporosis and osteitis fibrosis cystica, kidney disease, kidney stones, and nephrocalcinosis, GI disease, peptic ulcers, pancreatitis, and psychiatric disease. And so we referred to that with a mnemonic that many of you might remember. We called it bones, stones, groans, and moans. It was just an easy way to remember what people with primary hyperparathyroidism developed. Once again, today most people are asymptomatic. However, if you look very carefully, they're often not completely asymptomatic. So hyperparathyroidism is associated with osteoarthritis and with chondrocalcinosis, with pseudo-gout. Very subtle in some patients, but proximal muscle weakness is common in people who have hyperparathyroidism. Calcium deposition in the cornea called band keratopathy. I'll show you a picture in a moment. That occurs with long-standing hyperparathyroidism. And for unclear reasons, but very consistently, hyperparathyroidism raises blood pressure and suppresses hematopoiesis, so hypertension and anemia often occur. So although I say it's predominantly an asymptomatic disease, if you look very carefully, many people are not truly asymptomatic. This is band keratopathy. So this is calcium deposition in the cornea along the limbus. It tends to occur in bands as opposed to an arcus senilis that often is circumferential. The layer of the cornea that these calcium deposits occur in is different, and they look differently. They look different than an arcus senilis under a slit lamp exam by your ophthalmologist. So these are calcium deposits, and when you see these, that person has had hypercalcemia for usually a pretty long time, usually 5 years or more. So how do we diagnose hyperparathyroidism? The calcium is elevated. That's what makes us think about this to begin with it. The phosphate, this is the only type of hypercalcemia where we consistently see a low phosphate, because PTH drives calcium up and phosphate down. So when the phosphate's down, it's not diagnostic, but it's a big clue that you probably have hyperparathyroidism. The PTH level is usually elevated. Sometimes it's perfectly normal. Normal is not normal if somebody has hypercalcemia. So hypercalcemia of all other causes suppresses parathyroid hormone production. So if you had hypercalcemia malignancy, for example, the PTH level should be 0. So even a mid-normal parathyroid hormone level indicates that parathyroid hormone is what's driving that hypercalcemia. So normal or elevated PTH. Now, an important point, when we diagnose hyperparathyroidism, we often do a scan, a parathyroid scan or an ultrasound or a CT, to find out which of the parathyroid glands is increased, which is adenomatous, so that the surgeons know where to go when they do surgery. That is purely a localizing procedure. It's not a diagnostic procedure. So you make your diagnosis based on the biochemical findings. You may not always find a parathyroid adenoma. And why might you not? Well, 5% of people have ectopic parathyroid glands in the tracheoesophageal groove or in the mediastinum or elsewhere. Another small percent have very tiny parathyroid adenomas, and then 15% have hyperplasia where all 4 glands are mildly enlarged. So parathyroid imaging is not meant to be diagnostic. It doesn't tell you you have hyperpara or not. It just tells you if you have an adenoma and where that location is. The associations are what are very important to remember. When somebody has hyperparathyroidism, 90% of the time it's a sporadic disease and there is no association. We just need to get on with it and treat it. But about 10% of the time it's due to a familial disorder. These are germline mutations that tend to be autosomal dominant, so they occur in a large percent of patients, family members, so 50% in many cases. One type is fairly benign familial hyperparathyroidism, where half of their family members will have hyperparathyroidism due to hyperplasia. But the big ones that we really worry about are the ones that are associated with malignancies in other locations. So multiple endocrine neoplasia type 1 and type 2A are the big actors that we want to make sure we diagnose in people who have familial hyperparathyroidism. So what is MEN1? That's the 3 Ps. Everybody learns that, I think, when we're interns. Pituitary tumors, pancreatic islet cell tumors, and parathyroid hyperplasia. So these go together, and you can see that although, thank you, hyperparathyroidism is the only real benign condition here, parathyroid hyperplasia typically is the first condition to show up, usually in people's 30s or 40s. But they also develop pituitary tumors, and while these aren't malignant tumors, they're multifocal and they're very difficult to remove surgically. The pancreatic islet cell tumors most commonly are gastrinomas, Zollinger-Ellison syndrome, insulinomas, and about 60% or more of these are malignant. So when we see parathyroid hyperplasia, we need to have a very high degree of suspicion that other conditions more serious than the parathyroid disease may be present. Now these are all due to a germline mutation. And the gene that is mutated is called the menin gene. It was called menin because when it was described, no one knew what the gene did, so it didn't have a specific function, so they named it after the condition that it was discovered with, so it's called the menin gene. What's important about that is that it's commercially available, and if you have a patient who has multiple endocrine neoplasia type 1, 50% of their first-degree relatives are likely to have that same mutation, and so it's recommended that we do meningene screening in patients who have MEN1 syndrome. The other multiple endocrine neoplasia that we see is type 2A. This consists of medullary thyroid carcinoma, pheochromocytoma, and parathyroid hyperplasia. So parathyroid hyperplasia may occur early in this condition, and it's benign, but medullary thyroid carcinomas tend to be more aggressive than other types of thyroid cancer, and pheochromocytomas can be fatal if we don't diagnose them and remove them. This is also due to a germline mutation called the RET gene. The RET gene can be tested clinically, or in a commercial lab. 50% of all first-degree family members are going to have this same mutation. So if somebody has this condition, we need to screen all their first-degree relatives. So the importance of this type of hyperparathyroidism is not to miss the company that it keeps. People won't die of hyperparathyroidism, but they may die of medullary carcinoma, pheochromocytoma, or the islet cell tumors of the pancreas. Now, our treatment options. Surgery is the only way to cure hyperparathyroidism. You have to take the tumor out. Not everybody needs surgery, but if you're going to cure it, it's the only way to do it. If somebody has an adenoma, it's a fairly simple surgery called minimally invasive parathyroid surgery. We do a parathyroid scan. We find out which of the glands is enlarged. The surgeon makes a small incision over that gland, and they remove it. They measure PTH in the bloodstream right before they take the adenoma out. They wait about 15 minutes and draw it again. If your lab has a rapid turnover, if that PTH drops by 50%, then we have successfully cured hyperparathyroidism. This surgery takes about 30 minutes, and patients are usually same-day surgery. So this is the most common type, and skilled surgeons do this very quickly and very efficiently. It's a much more difficult issue if somebody has hyperplasia, where all 3.5 glands are involved, where all 4 glands are involved. They have to have 3.5 glands removed. So the surgeon has to go in and isolate all 4 glands, remove 3 of them, and half of the other. That half they may leave in situ, or they may take it out and put it in the strap muscle of the neck, or they may put it in the forearm. The reason they do that is the hyperparathyroidism often recurs, and when it recurs, they want it to be in a place where it's easy to go back and repeat that. There are patients who are not good surgical candidates, and if they need to have some treatment and they can't go to surgery, we have a medicine called cinacalcet. It binds to that calcium sensor receptor that I showed you on the 3rd slide, and binds to that and makes the parathyroid glands feel like the serum calcium level is higher than it is, and it suppresses parathyroid hormone production. So you can lower parathyroid hormone and normalize serum calcium with this medication. Since it doesn't cure the disease, it has to be taken chronically, so we don't consider this a first-line medication. But it is something we can use in people who are not good surgical candidates. The other thing we can do and should do, since lowering serum parathyroid hormone doesn't preserve bone, if we're not going to treat these patients surgically, consider an anti-resorptive medication, a bisphosphonate usually, to try to prevent bone loss in these patients with subsequent fractures. The most common ones that we've used in hyperparathyroidism are the bisphosphonates. When do we recommend surgery? So surgery is the only way to cure this. There's 6 criteria that we think about. If people have any one of these, we recommend they have surgery. If they have none of these 6 criteria, they actually can be monitored. And many people choose not to have surgery and just to be followed by their doctor. So if the serum calcium is 1 milligram per deciliter above normal, so at the University of Colorado that would be 11.5 or greater, we would recommend surgery. We always measure a 24-hour urine calcium. If the calcium is over 400 milligrams per day, we recommend surgery. Normal is 300. When it's over 400, their risk of kidney stones becomes pretty high. If the creatinine clearance is less than 60, we suggest that hyperparathyroidism with its hypercalcemia may have caused calcium deposition in the kidney, and this is what's causing the kidney impairment. so we recommend surgery. If the bone mineral density T-score is in the osteoporosis range or they have a fragility fracture, hyperparathyroidism promotes bone loss, so we should recommend surgery. If the people already have kidney stones or they're less than age 50. So when people meet these criteria, any of them, we recommend surgery. And if they don't, it's really reasonable, and a lot of people don't want to have surgery. It's reasonable to say, I'm just going to monitor you and see if you ever develop more severe hyperparathyroidism. And some patients will do fine. It'll never get worse, and you spare them a surgery. So those are our criteria that we currently use. So that's the most common cause, and I went into a little bit more depth on treatment. But then I want to talk about the other 4 common and important causes of hypercalcemia that we should not miss. So here we have a 69-year-old man who complains of recent weakness, nausea, vomiting, and a chronic worsening cough. So he goes into his primary care doc with these complaints. He has normal vital signs. That's his physical exam, overall normal. His serum calcium on routine testing was 15.2. His phosphate was not low. So that suggests this isn't a parathyroid hormone driven. That doesn't diagnose it completely, but it does give us a hint that this may not be PTH mediated. And he has some mild anemia. So what additional testing would we recommend? Well, of course, we always want to measure a PTH. That's the first thing to do, and it was undetectable, as it would be in anything other than hyperpara. But a PTH-RP was done, and it was 38. It was significantly elevated. So that suggests he has hypercalcemia malignancy. His SPEP was normal. 25 vitamin D was normal. What additional testing would be needed now? Well, he needs a chest x-ray, and a chest x-ray was done. He had a right hilar mass that turned out to be a squamous cell carcinoma. So hypercalcemia malignancy occurs in many different tumor types. There's 9 that are the most common, and the 2 on this list on the top are by far the most common. So lung cancer, especially squamous cell, and breast cancer, especially when it's metastatic, are the most common cancers that cause hypercalcemia. But head and neck, multiple myeloma, lymphomas, kidney, bladder, ovarian, and pancreatic, all are reasonably often associated with hypercalcemia. So we have to keep all these in mind. If a person has a known malignancy that's already metastatic, we don't have to go on a cancer search. But if we diagnose hypercalcemia malignancy and we don't have a cancer diagnosis already, we do need to look, and these are the places to start looking first. So what are the mediators? How do these cancers cause hypercalcemia? About 90 to 95% of the time, it's due to one peptide called parathyroid hormone-related peptide that these tumors make. The next most common mediator is 1,25-dihydroxyvitamin D that's made by lymphomas. And then we have a variety of other cytokines that are made by some tumors. Now, what's PTH-RP? Why do we have it? Why does it cause hypercalcemia? Well, first of all, it's a 141 amino acid peptide, and it's expressed only at certain times of life. So PTH-RP has several functions, and then others that we don't know yet. It appears to be responsible for the transfer of calcium from maternal circulation into breast milk. It's highly expressed in the breast in lactating women. It also seems to be the mediator of calcium transfer across the placenta. So there's 2 times of life in 2 different parts of the body where this hormone is normally expressed, and then it's repressed the rest of our lives. The other place we express a lot of it is skin, and I'm not sure why. So it has some functions, but most of the time this is a repressed gene. And in these types of cancers, it's de-repressed, and they make this hormone that's 141 amino acids. Well, how does it cause hypercalcemia? The first 13 amino acids are identical to PTH, to parathyroid hormone. And this is the part of the molecule that binds to the parathyroid hormone receptor. So PTH-RP has its own receptor, but it also binds to the parathyroid hormone receptor, and that's how it causes hypercalcemia. Because it's very potent and often in very high levels, it can cause severe hypercalcemia. So that's the usual mediator of hypercalcemia malignancy. So how do we diagnose hypercalcemia malignancy? Well, the calcium is up. That's what started the ball rolling. The phosphate is going to be normal. The most important thing is to measure PTH. It's going to be very low or undetectable depending upon how sensitive your local assay is. It shouldn't be normal and it shouldn't be elevated. You don't have to measure PTHRP if you have a known cancer. If you don't have a known cancer, you should measure PTHRP. It's usually going to be elevated. If PTHRP is not elevated, the next most likely mediator is 1,25-dihydroxy vitamin D. So hypercalcemia malignancy often requires emergency treatment. So a hypercalcemic crisis exists anytime the serum calcium is 14.0 or greater. So we need to consider that an emergency. We want to know the cause, but we need to treat it right away. We promote urinary calcium excretion by giving a saline infusion. The saline infusion will increase urinary calcium losses. Loop diuretics don't have to be added, but certainly if it's a person who has a tenuous volume status from heart failure, pulmonary hypertension, or any one of a number of other causes, a loop diuretic is usually a good idea. We want to inhibit bone resorption quickly and potently, so we usually use a parenteral route. Bisphosphonates, I'll show you a table later. They work, but they don't work right away. They work very well. The usual bisphosphonate that we use is zoledronic acid. The formulation of zoledronic acid that we use in this instance isn't reclassed. It's called Zometa. It's 4 milligrams instead of 5, and it's what we use for hypercalcemia malignancy and for metastases. Denosumab is another choice for for lowering serum calcium. It doesn't work quite as fast. Denosumab, when we use it to treat osteoporosis, is called Prolia. When we use it to treat hypercalcemia malignancy or metastatic cancer, it's called Xgeva. Calcitonin is not as potent as either of those, but it works much, much faster. So typically what we'll do is we'll start calcitonin plus either a bisphosphonate or denosumab. The calcitonin will drop serum calcium from where it is about 50% of the way to the normal range, but it'll do it within hours, whereas these others take a couple of days to work. Plicamycin I've never used. It's always on a list of things you can choose, and you can always remove calcium from the circulation with hemodialysis. So that was hypercalcemia malignancy. This is another of the 5 big causes that we can't miss. A 72-year-old woman has an elevated serum calcium on pre-op labs before undergoing elective surgery on her right shoulder. Her past medical history, she had esophageal reflux that was pretty significant, and she had osteopenia. Because of both of these conditions, she was taking calcium carbonate. She was prescribed or advised to take about 2,000 milligrams per day, but because of heartburn at night, she said, well, maybe I take a bit more than that. Her physical exam was fairly normal, but her serum calcium on pre-op laboratory testing was 14.1. Her phosphate was normal. I don't have that on here, but her creatinine was significantly elevated and her CO2 was significantly elevated. Oh, I do have her phosphates right there. So that was normal also. So this suggests it's not a PTH mediated, and it does look like this is going to be our 3rd most common cause of hypercalcemia. So what additional testing should we do? We always want to get a PTH. It was normal. PTHRP, undetectable. Her venous pH was 7.5, so she really meets the criteria for milk alkali syndrome. So milk alkali syndrome has a diagnostic triad, and this is currently the 3rd most common type of hypercalcemia in the country. There's a number of good references here from recent articles. The diagnostic triad is hypercalcemia, metabolic alkalosis, and renal insufficiency, usually an acute kidney injury that may or may not recover. It's associated with the ingestion of excess calcium and absorbable alkali, most commonly from calcium carbonate. And so this lady was taking calcium carbonate for her bones, but she was also taking it for GERD and was taking an excessive amount. The mechanism, how does that happen? Well, the excessive calcium intake, the body doesn't want to have hypercalcemia, so when you take in too much calcium, it puts it into the urine. So people develop from excessive calcium intake, hypercalciuria. That causes a calcium-induced diuresis, which causes volume depletion, leading to renal insufficiency. In this particular renal insufficiency condition, the renal bicarbonate reabsorption is increased, or absorption is increased, so the kidneys hold on to bicarbonate. So you have hypercalcemia, acute kidney injury, and metabolic alkalosis. The treatment for this, it usually responds pretty well to pretty aggressive hydration. You need to stop their calcium and their vitamin D until they're normal. They can restart it later, but they need to do it at a more moderate dose. Dialysis is often needed in these patients because they have such severe renal impairment when they first come in. So that would be the way we treat this condition, and then good education for that patient so she can avoid having this happen in the future. The next most common that we see, this is a 40-year-old woman who came to me from Boulder. She had an elevated serum calcium on her annual checkup. She had osteoarthritis. She took multiple vitamins and multiple supplements. It was one of these things where they were in a bag, a whole bunch of little bottles of all kinds of stuff. She didn't necessarily even know the name of all of them, but she took a whole bunch because she went to a vitamin cottage that said, take all this stuff. There was her physical exam, pretty normal. Her serum calcium was elevated. Interestingly enough, her phosphate was elevated. Now that's a clue to what the cause might be. Remember I said that if somebody has parathyroid hormone-driven hypercalcemia, the calcium tends to be high and the phosphate is low, because that's what PTH does. What makes calcium and phosphate both high is vitamin D. So vitamin D stimulates intestinal absorption of calcium and phosphate. So with vitamin D toxicity, you often have elevated calcium and phosphate. So that makes me suspicious, plus she's taken a whole bunch of supplements. So what testing would we do? Well, her PTH needed to be measured, but as expected, it was undetectable. But I measured her 25 vitamin D, and it was significantly elevated. And a vitamin D level greater than 120 is almost always going to cause you hypercalcemia. If you measured their urinary calcium, you'd find pretty amazing levels of urinary calcium excretion. They're very high risk for kidney stones. So the diagnosis here is just vitamin D toxicity. We don't recommend, the general recommendation for vitamin D intake from the Institute of Medicine is 600 units per day. Most of us in the bone field or in general endocrinology recommend about 1,000 units a day. 2,000 units a day might be necessary for a lot of people. We try not to have people take more than 4,000 units a day unless they have celiac disease or they're on anticonvulsant medications where they need to take more. But typically we don't see vitamin D toxicity unless people are on quite a bit more, over 5,000 units a day. Vitamin D excess leads to increased gastrointestinal absorption of both calcium and phosphorus, so they both increase. The calcium phosphate product in the bloodstream increases too, so the risk of calcification of soft tissues is increased more in this disorder than it is in other types of hypercalcemia. The treatment: hydration, get rid of the calcium, get rid of the phosphate, stop vitamin D intake until calcium and vitamin D are normal. A loop diuretic can often be helpful. So the last type of hypercalcemia, that's one of the 5 types that we can't miss, is illustrated by this patient here. It's a 45-year-old man who came in to his primary care doctor complaining of dyspnea on exertion that had been going on for about 3 or 4 months. Had a past medical history of hepatitis C. This was several years ago. These are his medicines at that time, alpha interferon and ribavirin. He didn't have really a significant amount of calcium intake, about 600 milligrams per day, mainly dietary, no supplements at all. He was 5'10", 185. Physical exam was remarkable for diffuse rales. His calcium was 12.4, and his phosphate was also elevated. So once again, that makes us think mechanistically that this is something raising both calcium and phosphate, and what does that is vitamin D. Okay, but he's not taking any supplements. So I don't think he has vitamin D toxicity, but I do suspect a vitamin D related mechanism. So what additional testing? His PTH was negative, PTHRP was negative, SPEP was normal. 25 vitamin D was normal, so he doesn't have vitamin D toxicity. He's not taking supplements. But his 125 dihydroxy vitamin D was significantly elevated. And what this tells me is that he's converting 25 vitamin D into 125 vitamin D at a very high rate. The enzyme that does that is 1-alpha hydroxylase. It's expressed in the kidney, but it's also expressed in granulomatous tissues and in hematologic malignancies. So that's where we have to go looking now. So what additional testing would you recommend? He's got RALS, he's got dyspnea on exertion. So a chest x-ray was done. He had hilar adenopathy and diffuse interstitial disease. A biopsy was done. He had non-caseating granuloma. So this was a case of sarcoidosis. So 125 dihydroxy vitamin D dependent hypercalcemia is reviewed in this article here. The most common cause of that is sarcoidosis. Sarcoidosis has a high level of expression of 1-alpha hydroxylase, and it takes even normal stores of vitamin D and pushes those into 125 dihydroxy vitamin D. When you have hypercalcemia that's mediated by 125 vitamin D, half the time it's going to be sarcoidosis, a very important systemic diagnosis that we need to know about. 20% of the time, roughly, it's going to be a lymphoma. Aside from that, granulomatous infections like histoplasmosis, coccidioidomycosis, different types of deep fungal infections, other granulomatous diseases like borreliosis. We saw one patient who had silicosis. She had granulomas in her breast from a leaking breast implant that caused a granulomatous reaction and hypercalcemia. That occurs in about 4%. About 3% are idiopathic. We've learned that that's often due to a mutation in the enzyme called 24-hydroxylase or cytochrome P 24-1A or A1 rather that inactivates 125 vitamin D. So that tends to be a genetic mutation. The mechanism here, once again, 125 dihydroxy vitamin D is produced by granulomatous tissue which expresses a high level of 1-alpha hydroxylase. The treatment is different. We always hydrate patients to get them to excrete their excess of calcium. But we use glucocorticoids, ketoconazole, and hydroxychloroquine, and we keep them on, in this case, a low vitamin D and low calcium intake. A loop diuretic can also be helpful. So this is a number of good articles that review granulomatous disorders and hypercalcemia and how to treat them. So I just thought I'd briefly go over the treatments once more and just tell you a little bit about their mechanism. Glucocorticoids are effective in reducing hypercalcemia and sarcoidosis by reducing the inflammation. The inflammation activates the 1-alpha hydroxylase. So by reducing the anti-inflammatory effect, 1-alpha hydroxylase activity is decreased. Glucocorticoids may have a direct effect on it also. Hydroxychloroquine also acts through an anti-inflammatory effect, whereas ketoconazole directly inhibits 1-alpha hydroxylase. So patients with sarcoidosis that get 125 dihydroxy D-mediated hypercalcemia usually need to be on chronic therapy with one of these medications to prevent recurrent hypercalcemia. And this is the one type of hypercalcemia that we do recommend patients not take vitamin D, even in basic replacement amounts. Most of the other types we treat, they resolve, and we can have them have normal levels of vitamin D. We don't like to do that in sarcoid patients. The last thing I want to mention is the hypercalcemic crisis. We get consults on this, our endocrinology consult service, multiple times a year. I just want to go over what the definition of that is and how we approach that in a logical way. Serum calcium greater than 14 or above is considered a hypercalcemic crisis. They almost always have symptoms. The most common features are dehydration, nausea, vomiting, acute kidney injury, mental status changes, cardiac rhythm disturbances, and EKG changes. As far as EKG changes, the most common one is a short QT interval. So here we have a normal QT interval, and it shortens significantly. When you want to know if somebody's hypercalcemia is a lab error or if it's real, look at their EKG and see if their QT is shortened. That'll verify for you that it's due to, that the hypercalcemia is real or not. Now, the opposite is true of hypocalcemia. When people get hypocalcemia, the QT interval prolongs. While I'm not talking about hypocalcemia today, we do see that after surgery, after thyroid surgery. The QT prolongs when people get hypocalcemic, and that's where we have to worry about giving drugs, certain antibiotics and antiemetics that may prolong the QT interval. The treatment options, excuse me, that we have, normal saline increases renal calcium loss, and that starts working within hours. Loop diuretics do the same. They work within hours. Calcitonin is not extremely potent, but it decreases bone resorption within several hours, and that's why with a crisis, we usually start calcitonin. I'll show you the dose on the next page. And it typically stops working after 48 hours due to tachyphylaxis. So it's not something you can use forever, but it gets the ball rolling quickly. Bisphosphonate, so I mentioned IV zoledronic acid, reduces bone resorption. It usually starts working within a day. So if your patient is in a crisis, you don't want to wait a day. That's why we use calcitonin along with the zoledronic acid. Again, that's Zometa. Denosumab, Exgiva, can also be used. It takes a little bit longer to work, but it may be a better long-term preventive measure. So either a bisphosphonate or denosumab may be needed to be kept on board. Glucocorticoids are useful predominantly with the 1,25-dihydroxy vitamin D mediated hypercalcemias. They decrease intestinal calcium absorption. They reduce 125 production by mononuclear cells. Calcium mimetics, they lower PTH, they'll lower serum calcium in somebody who has modest elevations, but they're not really useful in a crisis. And you can always use a low calcium dialysis bath to lower serum calcium. That works very quickly. So we always want to know the cause. Once again, going back to the mechanism, PTH-mediated and PTHRP-mediated hypercalcemia cause hypercalcemia by causing excessive bone resorption. So we give a normal saline infusion, and those are the doses. We give calcitonin subcutaneously to acutely inhibit bone resorption. And then we give a longer acting antiresorptive to inhibit bone resorption over a longer period of time, and consider dialysis if that's not being successful. If it's 1,25-dihydroxy-D mediated, their problem is not bone resorption. They do have some excessive bone resorption, but more important is an excessive intestinal calcium absorption. So we use glucocorticoids, acutely, normal saline, calcitonin to decrease bone resorption, and the zoledronic acid, low calcium dialysis bath. And remember to treat the underlying cause. If it's cancer, if it's multiple myeloma, and you don't want this to recur, treating the underlying cause can prevent patients from being readmitted with hypercalcemic crisis in the future. So I'm going to stop here, and hopefully I've stimulated your interest in hypercalcemia and how interesting it is to be a detective and find out what the cause is and to treat it in a mechanistic way because of the findings you've had on your laboratory investigation. So thank you for your attention. Questions?
How reliable is the testing? For example, is there any reason to repeat pH levels? Because and it should be maybe abnormal on a purely laboratory basis. How reliable are they in laboratories?
So the question is, how reliable are which laboratories? I didn't quite hear.
Really any of them, but specifically PTH and PTHRP, are they good clinical laboratories?
Right, okay, so the question is, how reliable are these assays and can we depend on them? Calcium is a very accurate test. Ionized calcium is not always an accurate test, so a lot of people do measure ionized calcium. You have to know your lab and know their technique to know if that's a dependable assay. We rely on total calcium at University of Colorado because we're not confident of our ionized calcium. PTH is a very accurate test. And you're really looking, it doesn't matter if it's 80 or 70, If it's elevated or normal, that's clearly demonstrates that this is PTH driven. And those assays are very accurate at detecting normal or elevated versus very low. So PTH is quite good. PTH-RP is not an easy assay to do. Not everyone does it well. Furthermore, we don't truly know the negative feedback relationship of serum calcium to PTH-RP. So sometimes if calcium is elevated and the PTH-RP is normal, you're really not sure what that means. Should the PTH-RP be low? So I would have to say, of all those tests that I mentioned, PTH-RP is not so accurate. Vitamin D is highly accurate. 125 vitamin D, pretty accurate. So I think you can depend on all of these tests, with the exception that PTH-RP is difficult and sometimes kind of leaves you wondering if you're getting accurate information. Yeah.
What was happening to the 18-year-old for the 18 months before he got to you?
So what was happening to the 18-year-old?
What was happening during the 18 months that he
Oh, during the 18 months. So the story was he was actually from Saudi Arabia. He was a member, turned out to be a part of the royal family of Saudi Arabia, and was at college and was just away from his family. And I guess he felt like, I'm away from home, and he was losing some weight and not feeling well, and didn't attribute it to anything. At 18, he'd never been sick before. And so when he did finally go into, actually the student health service, is when he was diagnosed with a hypercalcemia. Yeah.
Mike, thank you for a very thoughtful review. Would you comment about the timing of saline versus a loop diuretic in management of patients with hypercalcemic crisis?
So the question is, comment about the timing of giving saline and a loop diuretic in people with hypercalcemic crisis. Like a lot of things, I'm not aware of a randomized controlled trial or something that tells me definitively, here's what we know. I have seen data that in a person with normal kidney function and normal heart function, that adding a loop diuretic doesn't add very much. Just giving a lot of saline will induce a calcium diuresis that's very effective in and of itself. I think when I want to look at a loop diuretic is predominantly when I'm concerned about the volume I'm giving somebody and whether they can handle it or not. So that would be somebody with any type of hypervolemic disorder, congestive heart failure, pulmonary hypertension, maybe liver disease. And those are people that I would generally recommend giving a liter of normal saline first before I start a loop diuretic, just so that I don't impair their kidney function by making them they're already hypovolemic to begin with. So I think in the cases where you're going to do that, I'd like to have a liter on board before I start a loop. Yeah. Thank you very much.